afternoon. It's wonderful to be here today and to see so many of my friends and colleagues here at ASPS in person after so many years of video and sitting at my dining room table. So today I'm going to be talking about surgeon gender-related differences in operative coding and plastic surgery. I'd like to acknowledge all of my very talented colleagues who represent statisticians, ethicists, and surgeons, and a CFO of a major medical organization in the Midwest. It isn't a secret or a surprise that male physicians out-earn female physicians. This is true in all fields of medicine. It's true in all fields, period. But why is it? There's a large body of knowledge and education and research that has looked into multiple facets of potential where we could say, all right, this is why a guy earns more than a woman, and this is a valid reason. However, all of the factors looked at so far do not completely explain the differences in income. These differences are not found in work hours, in faculty rank, in specialty, institution or practice type, research productivity, leadership positions, whether or not you have a baby, and if you're married or divorced or single. All of these have been found to not be related to the 37 to 39% variance in income between male and females. So what are those differences? And in the various types of literature, we found that there's a $17,000 annual difference in income on fresh graduates in New York State. This is accounting for all other variants and practice types. The difference goes up to $76,000 for urologists. And this isn't just these are the average, after your logistic regression analysis difference. The baseline differences can be as much as $750,000 a year between men and women. And it's not just in the United States. My friends in Canada have a difference about 24% in income, and this is a different type of medical system. The difference holds in Austria, where there's a difference in 32% between men and women, and in Japan, an almost 20% difference between men and women. And there, as the number of children you have goes up, for men, your income goes up. For women, your income goes down. Other groups have tried to create systems whereby the sex pay gap is eliminated or at least reduced. And at the University of Alabama in the Department of Surgery, they put in a new compensation plan. Before the compensation plan, female surgeons earned 46% of their male colleagues, despite similar RVU production. And after it, they went up to sort of the national average, where they only earned 72% of their colleagues. Surgeon gender has been the only factor consistently found to be related to income disparity, despite all of this research and all of these potential factors. So you have to wonder, what are we not seeing? What type of research are we not doing to look into this better? And I feel that it's more of the sociology, how people communicate and how we relate to each other in a system. We haven't done this body of research, and I think in this area we'll start to find answers. I was walking by a counter when I worked at the University of North Carolina, and I saw one of these little throwaway magazines. And on the front was "Women cardiologists do different work and make less money than men." This was a project done at Duke by Dr. Douglas. And so I started thinking, I wonder if that could make a difference for plastic surgeons. In reading the article, of course, men and women make different amounts even after adjusting for all of these things, but just the word or the phrase job activities made me curious. And that was my light bulb moment for thinking maybe this is one of the reasons why. Could variability in billing and coding practices be responsible for that income difference that we see between men and women? So what degree of difference in coding would be needed to see an income difference? Doximity studies have shown that there's an average of about $44,000 to $49,000 a year difference in the incomes of male and female surgeons. And so if you had all of your income based on RVUs, and if we valued an RVU at $65, which is an average value found online, then you take $49,000 a year divided by $65, and that is a difference of 749 work RVUs difference between males and females a year. If you divided that into the year, that's only 14 RVUs different a week. which is a fairly small difference. And later on in the talk, I'll go through some ways in which you see those small differences. So it's not a big thing. I think it's a series of small activities and small events. I am an ex-director of the American Board of Plastic Surgery and have access to case lists for doing research. And so I applied to the board to get a de-identified list, the 9-month case list that we all turn in to do our oral boards, of 1,093 ABS board candidates between 2014 and 2018. We looked at total work RVUs per case, number of CPT codes per case, total number of cases, number of major and minor cases, surgeon sex, where they lived, and what type of practice environment. Are you academic, surgery center, military, etc.? The CPT codes were converted to work RVUs using an online standardized metric, and the codes were deleted in 2018 were converted to their most recent codes. 57 surgeons were not included because they weren't from the continental US, Alaska, and Hawaii. My final data set included 1,036 surgeons. A second list of surgeons without case data was provided, which included practice locations. This was done by the board so that I couldn't figure out which surgeon was generating which charges. And the practices were then defined by the authors of the paper to be academic, independent academic medical center, military, private practice, and a very few, I think 12, were unable to assess. The case list was then returned to ABPS. The two data sets were then melded. Our statistics were done by a PhD statistician and a master's level statistician, and unfortunately it is a little bit beyond some of my statistical knowledge, but we discussed this and she calculated which statistics were appropriate for this. Proc-Limix was used to analyze the statistics, and the alpha was set a priori at 0.05. We expressed the data as means with the confidence intervals, and a priori we chose a 10% minimum difference to be statistically significant, and all of this was done before we ever saw any of the data. Globally, the median case number for applicants during this time was 103 cases. Applicants were submitting about 1.82 codes per case, doing 72 major cases, 29 minors, and a median of 2973 work RVUs. At surgeon level data, in all practice locations, there were about 2 males for 1 female surgeon, and we start seeing this. So CPT codes per case, we saw a 5% difference between men and women, and this was significant. Our confidence intervals did not overlap. When you look at surgeon level data, this is where you see the biggest difference. The total work RVUs. Men billed 19.4% more than women, and obviously statistically significant. The mean work RVUs per case was also about 11% different between men and women. Furthermore, when you looked at the mean number of cases, it was a 9.9% difference, which is just under our level of statistical significance. But the mean number of major cases, and this was our kind of an unexpected finding, men billed 14.3% more major cases during this 9-month case period time than females did. And women billed slightly more minor cases. And here is a graph plot to show these differences. Then we looked at whether or not where you worked made a difference, and found that in an academic center, this was the one huge area for statistical significance, male surgeons billed 15% more than female surgeons. So what are some of the limitations of this study? This is a population of surgeons who were early in their career. Most people take their boards within 5 years of graduating from residency or fellowship. Cosmetic cases are not fungible. They have huge variability in charges provided. Other income streams were not able to be included in this group. These include office visits, hospital consults, non-invasive procedures, service, leadership, and research-related income. Reimbursement may not be directly tied to work RVUs. I've worked in multiple different environments, and in one of mine, if I billed 80 RVUs, I was reimbursed for 80 RVUs, whether or not the hospital was reimbursed for those 80 RVUs. Other places, you have to get a certain amount, and the hospital takes a certain cut and gives you back certain amounts. And certain surgeons may not be fully reimbursed for all codes. We know that for hand surgery, if you have 10 flexor tendons that have been cut, you'll get reimbursed 100% for the first one and declining reimbursement for thereafter. But I was just trying to find a metric that could be used that would be the cleanest of all. We found significant differences between males and females in the number of cases performed, the number of major cases performed, total RVUs billed, average number of work RVUs per case, and average number of CPT codes per case. But the difference in earnings related to major cases we find is one of the more intriguing parts and findings of this study. So let's look at factors that could be contributing to differences in billing and coding. So why do we bill differently for these things? It could be a lack of knowledge of the guidelines. When I have been going around talking to people over the years, most women will say, I don't want to be audited. I'd rather undercode than overcode because I don't want to be viewed as, some renegade wild coding person who's trying to game the system. Whereas I have talked to male colleagues who say, I'm just going to push it as much as I can, and if they tell me it's wrong, then they'll take the money back. And so I think that men may have traditionally a higher risk tolerance. More women that I've spoken with have a lower risk tolerance in this, and so you do see possibly differences in coding. And the research supports that. Overcoding and undercoding are common. Austin et al. Found a 28% error rate in coding among faculty and a 43% error rate in coding among residents. So if we're not being taught how to code, or if we're not getting reinforcement on proper coding, then inappropriate coding is possible. And Gala et al. Showed global undercoding among OB-GYN residents with improvement after education. And it's kind of interesting that about 85% of OB-GYNs are females, and so at the institution where this project was done, about 75% of the residents were females and 25 males. And then there could be a lack of awareness of the impact of your inaccurate coding over a period of time. So I think more education is needed. Working with your local coding specialist is really important because in our system we get chart audits done periodically, but I think that they should be done more frequently and in a more granular fashion, because it's important to find out how best to code your procedures, your notes, your cases, so they are accurate. And the system needs more accuracy as well to start defining which patients are sicker than other patients. And so it's not just you, it's the whole system. It's important to take courses in coding, and ASPS has nice little plastic surgery coding workshops. In the plastic surgery news, there's always a monthly thing on, how would you code this case? What are some problems related to bad coding or good coding? I think it's important to keep a list of the codes that you provide and see, when you submit them to your organization, what comes back. That way you can find out where you may be going wrong. And you want to make sure that they're billing for everything that was done. I had a minor heart attack when I was doing my board's case because I was reviewing the cases and the coders had seen radial artery laceration in my preoperative diagnosis and just assumed that I had done a radial artery repair even though I hadn't. And it was a Medicare patient. That's called fraud. And so I had to have a little discussion with them like, okay, you can never, add, always take away. But, while I'm in my board's collection phase, I want everything to be above board. And I probably am as bad as anybody else. I'd rather slightly undercode than overcode. But I'm learning more that it is important not to leave the money on the table and get reimbursed appropriately for the work you do. So let's go through just a few small things that can raise some of these points. So for wound closure, if you have a wound that's less than 2.5 centimeters and you do a simple closure, you get 0.8 RVUs. If you do an intermediate, it doubles it to 2 work RVUs. You're like, it's just 1 RVU. What if you do it for longer wounds, every day, more times? These things will add up. Remember, it's just 14 RVUs a week. And so, if you're being too conservative and say, oh, I forgot to measure the length of the wound, we'll just call it a simple wound, then you could be potentially leaving things on the table. Larger wounds, larger differences. And so a wound that's 7.6 to 12.5 centimeters, a simple closure, 1.44 RVUs, a complex closure, 4.74. And I'm not saying to code inaccurately. I'm not just saying, do things that you don't need to do or that you weren't planning on doing or can't be justified, because these things can get you into trouble. In-office radiography. I never used to bill for these things, and they're small, but they do add up. And it's been shown in the hand literature that you can certainly pay for your $30,000 ultrasound machine if you actually are doing an ultrasound and you do a fairly easy billing and coding for it. Why wouldn't you? And so you can start adding that to your regime in addition to adding the procedure. And using the image intensifier, if you use basic simple template for how you put that bill, then you are taking an image. You have that piece of equipment in your office, and you are actually making an official reading that could get you into legal, save you or get you into legal trouble. So you may as well be reimbursed. And then there are the things like variations in coding. And we all know that there's a certain amount of gamesmanship and art to billing and coding. So if you look at something like CMC arthritis, the procedure would be to excise a trapezium and do something with a tendon or something with something else to fill in that space. And we all know that there are dozens of variations on a theme on what you can do with this. So one way of billing, you could do a carpectomy. I'm taking out the trapezium and doing a tendon transfer. I'm moving tendons into that space. And the combined is almost 14 RVUs. I generally have done an arthroplasty with or without interposition, which is 11.74. Both of them are legal, both of them are fine, but it just depends on how you want to, and are you playing the game to a safe degree? You could also use an arthroplasty with a prosthetic. You can get tendon from someplace else. So there are all of these different ways you can legally, ethically, and appropriately code, and I think that there are people who don't really take advantage of certain legal things in the system. So going back to this, the average income difference, $49,000. If it were all based on work RVUs, that would be 749 work RVUs a year or 14 work RVUs a week. Not huge differences, but adding up to significant gains after a year. And the importance of being honest and above board cannot be underestimated, because we see not infrequent things where medical billers are sentenced to prison. People are increasingly hitting people with monetary claims. They're going back to get the money. They're putting people in prison. They're hauling you to court. So whatever you do, make sure that it can be justified, documented, is legal and appropriate. So which of the factors may contribute to the differences in the number of major cases, which I think has got to be one of the most fascinating things about all of this. And here's where I think we need more work done in the sociologic realm of how we do what we do as surgeons. What about things like referral patterns, privileged contracts, case mix assignments, inherent biases in how we see people, and I love this, the family-based breadwinner mentality. One of my colleagues earlier on in my career, he and I were complaining about our salaries, and he said, well, it doesn't matter as much for you, you're married. And I'm like, and how does that have anything to do with my life? I paid the same amount of medical school tuition. My husband isn't keeping me in some style that I'd like to be accustomed to, and this isn't my hobby farm. We should be getting the same work for the same amount of money for the same work that we do. So, how are patients assigned to surgeons' clinics? When you have a new faculty member, how do you, and that person may be microsurgery trained, is that new faculty person being fed microsurgery cases, or do we say, we've been always sending those cases to John, and so you can just build up your own case mix over time. But in the meantime, you can do the low-paying, butt ulcer clinic. Something like that. It's done. Young surgeons have not infrequently come up and said, hey, how do I get these things? The politics are keeping me from doing cases that I want to do and that I'm qualified to doing. How are clinics templated? This one was a little crazy, and it was a completely benign but stupid error. But when I first started at one of my practices, I wasn't getting a lot of new patients. And patients that were coming to see me were saying, I had to wait 6 weeks to see you. I'm like, I just got here. How can you wait 6 weeks to see me? Well, it turns out that the front desk used the established surgeon template. So it was 2 new people and 20 return visits. And so people were calling in, and they didn't say, oh, well, Dr. Kalliainen is new. She has no patients. She can see you. They're like, oh, I'm sorry, one of her, new patient slots is already, both of them are already taken. And so it can be really just stupid things that, you just need to check on how things are going, or things that maybe there's stuff underground or political things. Do surgeons have the opportunity to limit certain patients? AKA, does the group equitably share in the care of lower reimbursing patients? And that's something where you're the new person, you get patients who may not reimburse well here. Or does everyone kind of agree that, okay, nobody really wants to take care of case number X, but we're all going to do it because we are a team and we're a family, and we don't want to hit somebody with all of the low reimbursing cases when they're new in the practice. Are there hidden contracts that you may not know of? Somebody negotiated that, all right, you're going to guarantee that I do X amount of this type of case, and so you're going to funnel me these cases, only it's not above board and nobody knows about it. So is everybody working to the maximum level of their training? And are we assuring an equal playing ground for everybody? So I think our next steps are, we need to teach and learn how to optimally bill and code. But we also need to adopt a growth mindset and provide all faculty and all young surgeons with the opportunities to work to the maximum of their ability and desire. We can't continue with being in a fear mindset, but we need to adopt this growth mindset. And at that, I'm happy to address any questions. Thank you so much for your attention.
Hello, Dr. Kalliainen. Thank you very much for your
pleasure.
presentation. I'm Mihaela Rapolti, the Internal Medical Center. My question is, being aware of all this type of barriers as a young surgeon, what do you suggest me to do? I honestly took a picture of your slide and I will present it to my more senior colleagues to kind of really pinpoint where I think the problems are. Do you think this is advisable? Is this kind of too strong?
I think you have to be willing to poke the bear with a stick in this, because nothing that we've done so far is doing anything. So whether or not it's negotiating a better contract or looking at your clinic and saying, look, I am seeing all of these types of patients. These are the other types of cases I need to get. You may have to look at everybody's case mix and say, I need to get more of these than, and talk to the front desk and say, you need to start funneling me more of these cases. They may say no. At some point, you have to be willing to walk. But negotiation is important on the front end. The problem with this is that women, when we try to negotiate using the style that men typically negotiate with, it's a penalty for us because we're viewed as not being team players. It's not nice. Nice ladies don't talk about money. And so we are viewed negatively by using more aggressive negotiation tactics. I wish you the best.
Thank you so much for that talk. One question for you is, for the next steps of your project, did you do, or is the plans do any analysis to look for compensation differences or work review allocation in departments with women plastic surgery leaders versus male plastic surgery leaders? Because I imagine that may have a bit of an impact.
I think that the leadership level has to be higher, just to kind of get things going. So if you're a division of plastic surgery, it may be more difficult to get that than if you're a department chair kind of looking down at it. But it certainly is a start, because we know that for other things, when a minority or underrepresented minority is in a position of leadership, you do get more fairness and more representation. So I think that could be one interesting way to go. I think working with sociologists to start bringing them in to learn different ways of analyzing some of the material and seeing it differently are also areas of research. But this is such a wide area that I would encourage any of you, steal these ideas, go, do things, because there is an almost infinite number of things that we can look at in this field.
Thank you.
Thank you.
Thanks, Loree. That was just outstanding. And I just want to say, all the women need guidance and mentorship like you're providing. This needs to go beyond this little forum to subsets of discussion that embrace all the women in plastic surgery. You could be a leader.
Thank you very much, Rick. Hey.
Thank you so much for that talk. So I just wanted to add that when I was in practice, when I first started, I signed a contract. And a couple of years went by, I knew my productivity was going up, and we were looking for a new surgeon. So I went to our president and I said, I think I deserve a raise. Now, I didn't just go there for no reason. I had data to prove that when a because we had sparsity of our MOAs. So I said when our other surgeons weren't there, my productivity went way up. So I went there with the data of what I did by myself, what my RVUs were, and I demanded to have a raise. And it turns out that the new person they were going to hire, which was a guy, was going to be making more than I was making, and I'd been there 4 years. So I just want to add, don't be afraid to go in and ask for what you're worth, and just have some data behind you to back you up, because when they try to question you, then you have a good reason. And like she said, don't be afraid to walk. Because at that time, I was prepared to say if I wasn't given what I feel like I deserve, I was ready to walk. And you have to know what your leverage is and be able to use it appropriately.
Thank you. Yeah, knowing our value is really important, and some interesting studies have been done in the urology literature looking at women and saying, well, what do you think is a reasonable starting salary? And it was way below what, was being offered to men of same training. And so I think that as women, we tend to undervalue what we're doing, and that's on us. We do need to be a bit more bold, and that may need to start at earlier levels of training on how do we, learn more about what is a reasonable salary and how to get it.
Thank you so much, Dr. Kalliainen. I guess your talk kind of brought up two thoughts that I was having. One would be whether there could be a link between what patients' preferences are, whether patients have their own biases. And so they're on the internet, when they're talking to people, are they looking for a particular male or a female provider for their major cases or where they're going to undergo? So that would be an interesting thing to think about, whether that's playing a role. And the second would be that whether kind of the same study design that you had can be used for different races. So whether white versus African American versus Asian and all the other races, kind of whether there's discrepancies and differences in how they bill and whether they're getting paid more or less.
Yeah. Both of those are completely valid questions, and I don't think ABPS was collecting surgeon race during that time. I believe that ethnic background is becoming to be one of the things that are asked, so that would certainly be reasonable, and it is going to be, it would be significant, because when you look at reimbursement over time, black people lower, black women even lower, so that one is going to be significant. And the first one, who they choose. It's an interesting question on, but then are you marketing people for, the biggest position or, the biggest roles in the thing? So do patients even know who their options are? And some big research was done about a year or two ago that showed women had lower mortality and morbidity. So if you're going to say, come to see Fred, you got to see, but, Jean has lower mortality or morbidity. So I think that we should support people who are skilled in their job equally. And one of those things is, transparency in income. In my Minnesota practice, there was a thing that came out every month. You could tell what the income was for everybody. So the amount that you got for being a division chief was there, the amount that you got for maybe legal stuff was there, and the number of RVUs you generated and pay that you got was there. And so there was none of this kind of sneaky behind the scenes, is she getting more or he getting more? But it would be interesting to look at that practice to see if the males had a different practice type than the females. And that may be choice, or it still may be internal referrals. Thank you.
Thank you.
Okay. Well, thank you all so much for your attention, and I'm happy to address any other questions.